Hypertension. Definitions. What is hypertension? Hypertension is defined as persistently elevated arterial blood pressure, and it is categorized into four different categories according to the American Health Association: normal, elevated, stage 1 and stage 2, and a hypertensive crisis. Pathophysiology combines the study of disease and normal body function. Primary essential hypertension comes from an neonatology, while secondary hypertension comes from a chronic kidney disease or renovascular disease. And the major causes of death are cerebrovascular events, cardiovascular events, and renal failure. The clinical presentations for primary uncomplicated hypertension is going to be asymptomatic initially. For the secondary hypertension, is going to be symptoms of the underlying disorder, like CKD or renovascular disease. But the diagnosis should be made on the average of 2 or more readings taken at each of 2 or more clinical encounters. Elevated blood pressure may be the only sign of primary hypertension on physical examination. Let's imagine this. You're measuring a blood pressure of a person and you find it to be higher than 180 systolic and 120 diastolic. How would you tell if it's an emergency or an urgency? Hypertensive emergency is extreme blood pressure elevation with acute or progressive end organ damage. So it's with acute or progressive end organ damage. An urgency is extreme blood pressure elevation without acute or progressive end organ damage, end organ injury. What are the goals of treatments for patients that have hypertension? The overall goal is to reduce morbidity and mortality from cardiovascular events. Also, the American Heart Association guideline recommends a goal blood pressure of lower than 130 systolic and 80 diastolic for most patients. Now, for the non-pharmacological therapy, which are going to be lifestyle modifications, the most popular one is the diet a DASH plan. A DASH plan, basically a dietary approach to stop hypertension and eating an eating plan rich in fruits, vegetables, and low-fat dairy. Sorry. Salt reduction to lower than 1.5 grams per day. Weight, you're definitely recommended to lose weight. And activity 90 to 150 minutes a week. Also, like resistance training and aerobatic resistance. Habits, moderate alcohol, quit smoking. In the future episodes, we're gonna talk about why smoking and alcohol actually affects hypertension. Let's now talk about first-line drug classes. ACE inhibitors, ARBs, and CCBs, calcium channel blockers, diuretics, and beta blockers. All of those, no, I'm sorry, not beta blockers. Beta blockers are not a first line, but diuretics, CCBs, ARBs, and ACEs, those four are first line agents to treat hypertension. ACE inhibitors, which are angiotensin converting enzyme, their mechanism is basically the blockade of the conversion of angiotensin 1 to angiotensin 2. It's gonna block it and not make it able to turn to angiotensin 2. Very, very simple. Side effects: hyperkalemia, an abnormally high level of potassium in the blood. That's one of the most common side effects of ACE inhibitors. Acute kidney injury, and angioedema, which is a rapid swelling of the deeper layers of the skin, often around the face and lips. Please be very aware of the angioedema side effects with ACE inhibitors. And a persistent dry cough up to 20%. Why does ACE inhibitors cause a cough? Because it prevents the degradation of bradykinin. Okay, that's why it actually does make you have a dry cough. It's very important. It is also contraindicated in pregnancy. Let's talk about the brothers of ACE inhibitors, which are ARBs: angiotensin 2 receptor blockers. Directly block the AT1 receptor. That's their mechanism. Very similar to ACE inhibitors. ACE inhibitors make angiotensin 1 not turn into angiotensin 2. The ARBs just basically angiotensin 1, they're gonna immediately blockade it. Side effects are very similar to ACEs. Also renal insufficiency, hyperkalemia, but this is the make or break difference. No dry cough, no cough. It does not make the bradykinin degradation, does not block it. Also contraindicated in pregnancy. Let's now talk about calcium channel blockers, CCBs. Dihydropyridines, for an example, amlodipine is very popular for patients, for older patients that are taking hypertension medication. They are very, very potent peripheral vasodilators. Their side effects include reflex tachycardia, dizziness, and flushing and peripheral edema. Non-dihydropyridines like Vermapil and dialytism, these are currently very popular with older patients that have stage 2 hypertension. Negative inotropic effects can worsen heart failure, so you have to be very careful with these. Vermapil and dialytism can actually worsen heart failure, decrease heart rate, and Vermapil can cause constipation. Diuretics. Diuretics are categorized into 4 different types: thiazides, loop diuretics, and potassium-sparing diuretics, and MRAs. MRAs are mineral corticoid antagonists. Thiazides. They are the preferred diuretic. They're the most prescribed, and the most popular one is chlorothiazide. It's the first line option. So the first line option for diuretics is chlorothiazide. Side effects are hypokalemia, an abnormally low level of potassium in the blood, hypomagnesia. So you need to know that diuretics, hypokalemia. ACE inhibitors and ARBs are hyperkalemia. High potassium, low potassium. Hypomagnesia, hypercalcemia, and hyperuricemia, which is a high level of uric acid. Loop diuretics, for example, furosemide, are more potent for diuresis and are used in severe cases for chronic kidney disease and when the EGFR for the kidney filtration is lower than 30. Potassium-sparing diuretics are weak antihypertensive, counteracts potassium wasting. So, for me to explain this to you all, potassium-sparing diuretics cause hypokalemia, and one of their main side effects is hypokalemia. So these types of diuretics are counteracts the potassium wasting to prevent hypokalemia. MRAs are you need to know that MRAs are diuretics like spironolactone and epilerone used for resistant HCNN and HFrEF. Those are heart failure. We are going to heart failure with reduced ejection fraction. In another episode, we're going to talk about heart failure and what those words mean and what is the difference between this one and the other one. I don't think it's, yeah, HFPEF, reduced ejection fraction, and I don't remember the P one. Sorry. Used for resistant HTN and HFrEF, risk of hyperkalemia with the MRAs, hyperkalemia, spironolactone, and one of the main side effects of spironolactone is gynecomastia, which are enlargements of breast tissue in males. Beta blockers. Beta blockers are not first line unless a compelling indication exists. Cardiovascular beta 1, atenolol, bisoprolol, metoprolol, safer in asthma and COPD. So beta blockers are not used in first line cases only if a compelling indication exists, like the one that we talked about, compelling indications: heart failure, heart reduced ejection fraction, stable ischemic heart disease, and diabetes with albumin, CKD, and secondary stroke. Um, ICA, which stands for intrinsic sympathomatic activity, acebutolol and pinitrol, rarely used, do not reduce cardiovascular events as well as other beta blockers. Side effects are bradycardia, because they're gonna lower the heart rate, AV block, fatigue, and can mask hypoglycemia symptoms. Abrupt cessation, I'm sorry, English is not my first language, so I cannot really say those words correctly. Abrupt cessation should be avoided. Taper over 1 to 2 weeks. Basically means that you cannot, if you have been prescribed a beta blocker, you cannot immediately stop taking it. You need to like taper it like 1 to 2 weeks, lower the dosage until you're off of it. Uh, Other antihypertensive agents, alpha 1 blockers like prazosin, used as add-on therapy, so it's not going to be used alone, can also help with benign prostatic hyperplasia. Direct renin inhibitors like alcycrin, they have a very limited role, blocks the renin angiotensin aldosterone system at its activation point. For the central alpha 2 agonists like coldinine and methyl dopa, they're going to be used for resistant hypertension. HDN stands for hypertension. Methyl dopa is a choice for pregnancy induced hypertension. So, if you have a pregnant woman and when she wasn't pregnant, she didn't have hypertension, but after she got pregnant, she did get hypertension. So it's a pregnancy induced hypertension. The drug of choice would be methyl dopa. And for resistant hypertension, it would be coldinine or methyl dopa, but I see coldinine being prescribed much more often. Direct arterial vasodilators like hydralazine. This drug is becoming very, very popular in combinations drugs. It directly relaxes the arteriolar smooth muscle. Special populations and emergencies. For pregnancy, preeclampsia, which is a complication with high blood pressure, a pregnancy complication with high blood pressure and signs of damage to other organs, often the kidneys. A new onset hypertension higher than 140 systolic over 90 diastolic. After 20 weeks gestation plus proteinuria or end organ damage. So this is what preeclampsia means, and the measurement of the blood pressure of it. Eclampsia, a severe complication of preeclampsia where high blood pressure results in seizures. So this is very, very, very serious and dangerous. It results in an onset of convulsions in preeclampsia, which is a medical emergency. Save medications for chronic hypertension in pregnancy are Lipitor, long-acting nifedipine, which is CCB, methyl dopa are first line. So for chronic hypertension in pregnancy, the main three drugs that are safe to take: a Lipitor, which is a beta blocker, a long-acting nifedipine, which is a CCB, and methyl dopa are first line, which is, we just talked about it. It is a central alpha 2 agonist. Now, for children and adolescents, secondary hypertension is more common, so a workup is needed. Lifestyle changes are key, but ACE inhibitors, ARBs, beta blockers, CCBs, and thiazides are all acceptable drug choices. Those are the main. ACE, ARBs, CCBs, and thiazides are the first lines, but you also see beta blockers because most of the time those kind of patients have a compelling indication. Black patients, CCBs and thiazides are most effective and should be first line without a compelling indication. This is very important. Calcium channel blockers and thiazides are very, very effective in black patients and should be first line without a compelling indication So you're gonna be with a compelling indication, you're most often gonna you're gonna use beta blockers. Hypertensive urgencies and emergencies, like we talked about it, for urgencies managed with the short-acting oral drugs, captopril, codeine, and Lipitor. I'm sorry with my pronunciation of the drugs. It's very hard to say them. Emergencies require immediate blood pressure reduction with a parental agent to limit end organ damage. To be honest, guys, I'm really just doing these videos because I have a lot of people that I'm seeing get to the hospital and they have a hypertensive urgency or an emergency, and their blood pressure is through the roof. So please pay attention. You could save a life one day, you don't even know. For an urgency, managed with a short-acting oral drug like captopril, codeine, and Lipitor. For an emergency, immediate blood pressure reduction with a parental agent to limit end organ damage. Evaluation of therapeutic outcomes. Evaluate blood pressure response in the clinic 4 weeks after initiating or changing therapy. Uh, how we're going to tell if that drug, if the prescription that we prescribe to the patient is actually working for them, we're going to check with them 4 weeks after to check his blood pressure goal. Once goal blood pressure is obtained, monitor every 3 to 6 months. Okay, assess patient adherence with the regime regularly. Key takeaways and summary. Let's. This is also, by the way, guys. I'm gonna put this HTML file in the description. I made this with Gemini. It's from our lectures. It's very useful, and yeah. Now let's summarize the lecture. The goal to treat every single hypertension patient is to reduce their blood pressure to lower than 130 systolic to 80 diastolic for most patients to decrease the cardiovascular risk. For the lifestyle first. Lifestyle modifications dash diet, as we talked, which is a low sodium diet, a weight loss, exercise, and low sodium are foundational for all patients. First line drugs for most initial therapy involves an ACE inhibitor, ARB, CCB, or a thiazide diuretic. And a stage 2 hypertension often requires two first line agents. A compelling indications are crucial, which are the patient's other health risk conditions like heart failure, chronic kidney disease, or diabetes are key to choosing the best drug. Beta blockers are for these specific indications, not usually for initial hypertension treatment alone. So, like we talked, but beta blockers are not first line agents if the patient does not have a compelling indication, but if they do, it's a first line agent. No key side effects. Remember the classic ACE-induced dry cough because it does not make the bradykinin degrade. ARBs don't cause this, but only the ACE inhibitors do. Watch for hyperkalemia with ACEs, ARBs, and MRAs, and hypokalemia with thiazides and loop diuretics. Special populations, not all diuretics cause hypokalemia. Because we have the counteract potassium diuretics and MRA diuretics do not cause hypokalemia. Special populations in black patients, CCBs, and thiazides are often more effective in pregnancy. ACE inhibitors, ARBs, are conjugated saver options for Lipitor, nifedipine, and methyl dopa. Urgency versus emergency. A hypertensive emergency involves end organ damage and requires immediate treatment with IV medications. At the end of the lecture, there is a test that you could take after studying it, and also let's just answer one question. A patient taking spironolactone might experience which side effects which is rare with epilepsy? Gynecomastia. You got one. You scored 1 out of 12, which is the lecture. Now, after you answer it, you get this. The lecture notes under mineralocorticoid receptor antagonist, spironolactone may cause gynecomastia in up to 10 percent of patients this effect occurs, rarely with Eplenar. These are, I hope that these help you all when studying this lecture. Also, I wanted to talk about the compelling indications and how to treat them. These are specific comorbid conditions where certain drug classes have proven benefits beyond just lowering blood pressure. Heart failure with reduced ejection fraction and PEF. ACE inhibitors, ARBs, then add a beta blocker at MRA. That's how you treat reduced ejection fraction. And for this, diuretics for edema, ACE inhibitors, and or for a beta blocker. For stable ischemic heart disease, we're gonna study this in the last lecture. Beta blocker is the first line, and then we're gonna add an ACE or an ARB. At diabetes with albuminuria, we're gonna add an ACE inhibitor or ARB, it's first line. Chronic kidney disease, ACE inhibitor or ARB to slow disease progression, and then secondary stroke prevention, thiazide diuretic or a thiazide with ACE inhibitor and ARB. Thank you.